Okay, while we're waiting for the last couple of people to join, I'll just do a little housekeeping. So the next 2 weeks, the conference will be on hiatus for the holidays. So everyone, please have a wonderful holiday. And then we come back in January 7th of the new year with Tom Quinn and the kickoff for the annual HIV course. And that'll be on January 7th. And he's going to tell us about the global state of HIV. Then on the 14th, we'll again have a cases conference, which I'm going to put out the request again for anyone who's thought for more than 10 minutes about a patient. Please consider that to be interesting and feel free to send it along. And I'm happy to do the legwork and setting up the details so that, and if I know about it, we can invite smart people to talk about it. So please, anybody, everything is interesting. Please send cases along. And that would be for the 14th of January. And then the 22nd of January, we're lucky to have Annie Antar is going to come and talk to us about long COVID and her investigations of COVID and HIV co-infection. So looking forward to that. And if anybody has any patients that they've had in the clinic who they think have HIV and long COVID or has had clinical issues arise around that issue, I think it'd be great to send them along. We can give them to Annie and see how she can work it into what she'll talk with us about. Okay, and so then I think we can get started. We're really lucky today to have Dr. Raju from the Pulmonary and Critical Care Department, who's here to give us an update in treatment strategies and asthma care. And he is the person who has actually publicly expressed his willingness and enthusiasm to see our patients, which is like the most wonderful thing. So anybody who has people with pulmonary disease and whether it's asthma or other types of pulmonary disease, as far as I'm aware, you don't discriminate against other lung problems. He is the person who will see your patient and also is quite in tune to the issues of HIV and infection in the pulmonary setting. So without any further ado, I'll hand it over to you. You might want to switch to presenter or there you go. You got it.
Great. Thanks so much. And as mentioned, so I'm Sareth Raju, one of the Pulmonary and Critical Care faculty members. Also have interest in chronic respiratory disease amongst persons living with HIV and do some work in the SHIELD and the MAX-WISE cohorts related to long-term pulmonary complications. But today I was wanting to talk about what a lot of my practice is focused around asthma care. And, I was asked to give this talk surrounding treatment strategies and updates in asthma, because asthma is sort of a very common problem. And after, many years where really things hadn't really changed for care for asthma in the past few years, there's been a lot of significant updates. So just wanted to share some of that with you. So some of my, as far as my objectives, I'm going to focus on three main areas that have changed in recent guidelines. One is to review updates to the diagnosis of asthma, which recent guidelines have really honed in on the importance of, and to provide some review for evidence for changes in the approaches to mild asthma, which is an area of probably the most significant change, in addition to people on the other end of the extreme that we see a lot in our clinics, so those who with severe asthma and the availability of new biologic therapies. So I'll go through some epidemiology really quick. I think we're all aware that asthma is a national crisis. There's a high burden of asthma in this country. And it's a big source of disparities in addition to healthcare utilization. It can lead to, missed work, missed school days in children, and particularly impacts people with incomes with high poverty rates. There are additionally significant racial disparities with a greater prevalence amongst the African American community as well. Making it local with here in Baltimore. Baltimore is an area where the prevalence of asthma is closer to 14% in adults, which is much higher than the national average. And particularly amongst children in Baltimore, there's a prevalence that's nearly 3 times the national average as well. So it is a condition that is particularly relevant to our patients here in Baltimore. As far as a connection with asthma and HIV itself, well, this association I think is still being defined. There's some research that suggests Amongst pediatric HIV cases, there may be some increased asthma risk in children, although the data actually isn't that clear in adults. There's some small studies of allergic sensitization and eosinophilic inflammation being increased in people with HIV. The graph on the right is from a study in CID where they looked at FeNO, which is a measure of biomarker of eosinophilic inflammation that we sometimes use in people with asthma, that was sort of higher in people living with HIV, although we don't really know how to put that into clinical context quite yet. So I would say that studies of asthma and HIV are still ongoing. That being said, asthma is a very common problem, relevant to many different care practices, and it is sort of a common disease we see on a day-to-day basis. And there are a number of guidelines that have been put into place that are focused on how we take care of people with asthma. And additionally, these guidelines are developing. One big source is from the NIH, which puts out a report that actually hasn't been updated in some time, called the Expert Panel Report. The most common guidelines that are where we focus on, that are updated quite regularly, from the GINA Society or the Global Initiative of Asthma. And these are the guidelines that have continuously been updated in the past couple of years, that have been noted to be associated with a number of significant changes for asthma care. So in the rest of the time, I'll try to present a case that hopefully demonstrates some of how these guidelines are put into practice. So I'm going to focus on this case surrounding a patient I'm going to call Mr. W, who's sort of indicative of a lot of the patients we see. He's a 24-year-old with a history of childhood asthma. Sort of has an atopic history with allergic rhinitis and atopic dermatitis, treated with topical steroids. Not a lot of past medical history otherwise. He sort of comes to clinic today after he went to the emergency department 1 month ago with wheezing, dyspnea, cough, and was discharged with a taper for prednisone and albuterol or short-acting beta agonist as needed. So I guess the first question to ask when you see this patient is, what is asthma? And I'm going to hone in on this because being much more clear on our diagnosis of asthma is especially more relevant with some of the treatment changes. It's very important to note is that asthma, I think it's a common but complex, and I'm going to emphasize this, it's a chronic disease that is characterized, while it's a chronic disease, by variable and recurring symptoms such as shortness of breath, wheezing, and cough, associated with airflow obstruction, or meaning people take a long time to get air out of their lungs, bronchial hyperresponsiveness, meaning airway bronchial constriction, that is driven really by chronic airway inflammation. And it is that chronic airway inflammation that leads to lungs or airways that look like the one on the left, where the airways become inflamed, they produce thick mucus, and they can have variable bronchial constriction that is sort of a downstream of impact of that chronic inflammation. But that's something they're experiencing ongoing amongst individuals with asthma. And as I mentioned, but with the definition, although there's chronic inflammation, there can be some variability in symptoms, and there's variability in airflow limitation. So some key points with diagnosis is, one is that there's no gold standard test that will tell you 100% that this person has asthma. And asthma is essentially a clinical diagnosis. And with that, you're looking to make this diagnosis based on their clinical history that's consistent, having lung function tests that show this airflow obstruction that's at least once. We look for variability in airflow, and I'll talk a little bit about how we identify that. And then you want to look for the absence of symptoms that are really inconsistent with this diagnosis or point towards something else. Now, with anyone who presents to you with shortness of breath, there can often be overlap with other conditions. I bring up these diagnostic points because there's been a number of studies in recent years that have suggested that when they've reinterrogated, and sorry, this is showing kind of blurry here, but this is a large study from Canada that looked at individuals from a number of different group practices where an asthma diagnosis was given. And then when they really interrogated that diagnosis using peak flows, lung function tests, withdrawing asthma medication, they actually ruled out asthma in about a third of it. So, asthma can often be a diagnosis that's sort of thrown around when you find shortness of breath that you can't attribute to other causes. So with us in recent years, we're really focused on when people are labeled as having asthma, making sure that they have that diagnosis. And within these next few slides, I'm going to talk about three different aspects of confirming that diagnosis. One is a history that's consistent. So asthma will often begin in childhood. Allergies are common. We know we've talked about some of the common symptoms, but they're often associated with triggers such as different allergens or different environmental triggers that might lead to disease symptoms. Part of this, like many things, is a careful history and physical exam, and you're looking for factors that, is there shortness of breath? Could this be attributed to another cause, such as cardiac diseases that are common with older patients? They have a cough that could be caused by other conditions such as acid reflux or medication-related effects, or they have wheezing, making sure that's not attributed to another cause, such as if they're a long-term smoker with COPD. Sort of becomes very important to think about making sure that their history is very consistent with that diagnosis. And then we think about lung function testing, or what we call spirometry, to really hone in on the diagnosis. And you would be surprised, and there actually ends up being a high percentage of people who've been given the diagnosis of asthma that have never had formal lung function testing to confirm that. So within our practice, we're very big on honing in on utilizing that to confirm the diagnosis. And one of the key features about asthma is the definition of variability in airflow. So asthma, while it's associated with chronic inflammation, there could be variability in symptoms, and there could be variability in lung function testing. And there are a number of ways that we look for variability in airflow. One is during our lung function test, we do a test called a bronchodilator reversibility test, where we do lung function tests, give an individual an inhaler, look for an improvement in a measurement called the FEV1, which is the main thing we pay attention to, and we look for an associated increase. But you're not always going to be able to pick up variability in every patient, especially when they're well treated and controlled. We actually commonly utilize a peak flow diary, where we give an individual a peak flow meter, and we ask them to breathe into it in the morning and night over a 2-week period, and look for variability over time. And this figure on the right is sort of indicative of that, which is what we actually commonly utilize in our pulmonary clinics to help further characterize asthma. The other way to look for variability is essentially we do a therapeutic trial where you put someone on a long-acting inhaler, such as an inhaled corticosteroid, and look for a significant improvement. Sort of the most sensitive test to look for variability or bronchial hyperresponsiveness is a methacholine challenge test, which you hear about in internal medicine training, and I'll let you know that we actually rarely do that unless we were really skeptical of the diagnosis, and we really need to rule it out. And typically people should be referred to our clinic before utilizing this test. So I'm not going to go into too much detail, but we don't do it that commonly just because it can actually induce asthma symptoms. So we don't actually want to provoke that unless we really need to do more work to confirm the diagnosis. And this is just a figure from the GINA guidelines that I'll put in for reference, which is part of the recent update that sort of gives you a overview of how to confirm the diagnosis, starting with your history of physical lung function test, and different pathways to confirm the diagnosis before putting an individual on treatment. And when I talk about some of the treatment updates, it'll emphasize why it's extra important now to confirm the diagnosis of asthma. Now, helping to put this into context, I'll bring it back to the case of Mr. W, who's presenting to clinic today after completing a course of prednisone for what is presumed to be an asthma attack. Since that time, he's had shortness of breath and wheezing, and utilized a rescue inhaler 2 times a day on most days. And he's waking up every night with wheezing and shortness of breath. And he uses a rescue inhaler with some relief. So in clinic, he gets lung function tests, he does other things that show that you feel like are consistent with the diagnosis of asthma. But how do we assess his severity and control? And that is another key component I think we often think about in asthma management. And what we talk about in pulmonary clinic most primarily is something called asthma control, which is how often someone has symptoms, and such as shortness of breath, nighttime awakening, limiting activity, how often they're having flare-ups or exacerbations, events that may require prednisone to get their disease more controlled, which is a slightly different concept than asthma severity. meaning which is a measure of how much medication is needed to control someone's disease. Meaning an individual who has very severe asthma might require multiple medications to control their disease, but when they see you, because they're on a number of medicines, they may be well controlled. I'm going to be talking about the concept of control more often during this talk today, and it's how we reassess people's symptoms on a day-to-day basis to make sure we are treating them appropriately. And reassessing asthma control becomes important because the goal of asthma care is essentially to make sure someone is symptom-free and that they're on appropriate therapies and that we're taking the appropriate steps to control their symptoms as much as possible. And assessing control involves assessing daytime symptoms, assessing their rescue inhaler use, their nighttime awakenings, and their exertional limitations. And there are a number of different scoring systems, but this is just one mechanism by how we assess control and reassess to make sure people are on appropriate medication therapy. Now, putting this back to one of my original points is that remember with all this that asthma is a chronic disease. So even if someone's symptoms are well controlled, they still have asthma. And though there may be some episodic nature of their disease, it is chronic in nature. And the GINA guidelines continuously reinforce that it's important to continue to assess their control, their risk factor disease, and making sure that they're on appropriate therapy throughout. And with that, I want to get into the bulk of the talk where the majority of changes have been made. So trying to put this in context of Mr. W, we feel, his symptoms are consistent with asthma. He's fairly poorly controlled. He's using his rescue inhaler twice a day. He has nighttime awakenings. He has a recent exacerbation requiring steroids. So how do we decide at that point what therapy to put him on? As many of you guys are, I'm sure, already aware of, there are numerous inhaler options for people with asthma. This is a figure that sort of depicts our different inhalers that are available. They come in two sort of categories where we talk about relievers, such as there's a typo here, but it's short-acting beta agonists. At least this is traditionally what we thought about. And then controllers such as inhaled corticosteroids. I'm going to be referring to them as ICSs probably throughout the talk, and and then after long-acting beta agonists, which we refer to as LABA, and then long-acting muscarinic antagonists, which we refer to as LAMAs. And I will remind you that this group that's been highlighted in the red box is that really inhaled corticosteroids remain the backbone of chronic asthma care to address that chronic airway inflammation. And this is in contrast in somewhat to COPD, which we're not talking about as much, where corticosteroids are a little bit less important in the treatment algorithm. So how do we select which treatment to put individuals on? Well, the GINA guidelines has this step-up therapy, which is really used to decide an individual's initial therapy followed by how to step up therapy based on disease control. So we're really assessing where to start initially based on how frequently they're having symptoms, whether it's most days or less than twice a month. And that tells you a sense of which controller to pick. And from there, if their symptoms, if you start on step 3, for example, if their symptoms remain poorly controlled, you know where to step up to the next step after that. And that is how these guidelines are really put into place to assess disease control and how to step up therapy. Now, one of the biggest changes in the guidelines came in 2019. And even though it was a couple of years ago, this information is still being disseminated or still being put into practice. And it's really the change in reliever therapy, where we're traditionally took an approach where we would consistently use short-acting beta agonists such as albuterol as our controller therapy. But really in 2019, based on evidence that happened around the time, there's a switch to introducing inhaled corticosteroids earlier in treatment and suggesting that we use an inhaled combination of an inhaled corticosteroid and a long-acting beta agonist called formoterol to provide both control and relief of asthma symptoms as needed, which is a significant change in practice. And I'm going to talk about some of the evidence behind that change and sort of how we've been putting into practice. One thing I'll note is in these 2021 guidelines, they still emphasize this approach that was outlined in 2019, but they just presented it as a 2-track system to help improve some of the practicality of implementing this into practice. And I'll go over that at the end. So talking about why some of these treatment updates were made, and some of the clinical context was, what we really were not realizing is that there were a lot of hidden risk of what was considered mild asthma, meaning people with very intermittent symptoms that were classically described as mild. And what we were learning was that a lot of people who had acute asthma attacks, a high percentage of those were near fatal asthma, and a lot of asthma deaths occurred in individuals who in the 3 months prior had rare symptoms, often less than weekly. Although they still had asthma, as you know, asthma is a chronic condition that underlies things. And a lot of these patients were over-relying on their short-acting beta agonist because it provided relief, but this would often lead to overuse of their albuterol without use of controller therapy. And this would lead to rebound hyperresponsiveness with airway constriction and increased allergic response and eosinophilic inflammation in the airways. And they were continuously using a medication that wasn't really addressing the underlying pathophysiology of the disease with addressing the chronic airway inflammation. So a couple of studies happened in recent years, primarily in 2017 and 2018, that really highlighted the differences. But starting with the background is that, you know, prior to these recent studies, there wasn't really any evidence supporting just using short-acting beta agonists only for people with step 1 or mild therapy. And there wasn't really a lot of evidence for not giving a low-dose inhaled corticosteroids for people with rare disease. It was just clinical practice. But a couple of studies investigated the use of a combination of an inhaled corticosteroid, which was budesonide formoterol, with a low dose, which is sold here under the trade name of Symbicort, as both a controller and a reliever, meaning within these studies, individuals would use this inhaler as needed when they have symptoms periodically throughout. And the reason this inhaler was chosen is not that there's some magic behind the inhaled corticosteroid budesonide. It's more the formoterol or the beta agonist or component that relieves bronchoconstriction. Has a quick onset, so it provides relief, but it also lasts for a long time to help keep those airways open. So that is why that was chosen in these initial studies. And the 2 studies that really looked at this were the Sigma studies, which are Sigma 1 and Sigma 2, which I'll talk about some of the evidence that these found. And there's a number of studies that looked at this strategy. Sigma 1 and Sigma 2 are the one I'll talk about. The practical and the novel start trials or other trials that have also shown similar results. And these trials were both large multi-center studies across countries, although primarily a lot of the patients enrolled in these studies were from European countries. It was a placebo-controlled trial with multiple arms. Sigma 1, which is the one I'll talk most about, looked at the risk of individuals were given a placebo plus terbutaline as needed, which is an equivalent to albuterol, versus the budesonide formoterol as needed, versus utilizing maintenance inhaled corticosteroid such as budesonide twice a day plus terbutaline as needed. And they're primarily looking for asthma control and exacerbation risk. And these are all primarily individuals with mild asthma who are enrolled in these studies. And the results are pretty profound here. And just to highlight, the group in blue is the terbutaline only, or just the short-acting beta agonist only. These 2 groups in the black and red are those who are either using budesonide formoterol as needed or a maintenance inhaled corticosteroid. And what we saw is there was a significant decrease in severe exacerbations, even in people who had mild asthma who used this inhaled corticosteroid, long-acting beta combination as a reliever therapy. We also saw that compared to people who utilizing a maintenance strategy with an inhaled corticosteroid versus using an inhaled corticosteroid with the long-acting beta agonist as needed resulted in similar levels of asthma control, while giving these individuals a much lower dose of inhaled steroid than they would otherwise if they were just on maintenance therapy, suggesting at least non-inferiority in that case. And one thing that's notable across arms, there wasn't really a significant difference in adverse outcomes that you would think that we often think about in inhaled corticosteroids. So these often include thrush, changes in voice, and an increase in respiratory infections. There was more adverse events in the short-acting beta agonist only group, the terbutaline only, but those adverse events were primarily asthma related from poor control and exacerbation. So this was one of the big studies that led to a big change in how we do our practice. This is again just pointing to the non-inferiority of utilizing a inhaled steroid with a beta agonist as needed versus just putting someone on maintenance BS9 every day as needed. And it was showing a major decrease in the amount of inhaled steroid that those individuals needed who in the group that just used that in the as needed or PRN arm. This is just a systematic review that I've included as for reference that have shown that there are a number of other studies that have been available that have sort of replicated these results in recent years, all going in the same direction. So the results have been consistent across trials. So really, that is what ended up changing how we approach our sort of stepwise algorithm for how we approach asthma care. So one is that we first, start with confirmation of the diagnosis first and foremost, and then we can walk backwards from the stepwise workflow where, if they're very symptomatic, you put them on step 4 therapy, which I'll talk about a little bit. If they're not very symptomatic on most days or most weeks, or if they're just having symptoms twice a month, you go down to the step 2 or step 1 category where you have the option of just putting them on this as needed low dose inhaled corticosteroid formoterol, which ends up being Symbicort, low dose Symbicort in our practice, where they can use that both for relief and for maintenance of their therapy and decrease their risk of future exacerbations. Now, I will be one of the first people to admit that this has some barriers to implementation. And those barriers of implementation could be a few things, which we need to work a little bit better as a community to discuss. One could be from insurance company coverage and understanding, because this is a different practice. Most prescriptions are used to a medicine like Symbicort sort of being used as a maintenance therapy. And the other barrier is often just, education changes for individuals who have had asthma for a very long time. They're used to using their medicines like albuterol as needed. So it can be a practice change for someone who's had asthma their whole life. So that does require some education. The GINA guidelines did recognize this to some degree and sort of incorporate the secondary track where if individuals continue to use their beta agonist, their SABA or albuterol as needed as their rescue inhaler, they just encourage them, at least in the mild group, to utilize their inhaled steroid on those days just to improve disease control, because essentially if they're at the point where they're having to use their rescue inhaler, that does indicate some poor disease control that needs some level of maintenance or inhaled steroid to address that airway inflammation. So like I said, this is a significant change, and we're still figuring out the best ways to put this into practice. I will say I find this most easy to do in new patients where I've had a new diagnosis of asthma. But if there are a lot of questions that are associated with this, we're open to discussing that more as well. But I will sort of point out that this ended up being one of the biggest changes in the guidelines. And like I said, we're still figuring out how to sort of consistently implement that into practice. And this, like I said, this is primarily a change for individuals with mild asthma treatment. Now, jumping back to our case for Mr. W.
Sarah,
Yep.
would you mind if I just ask a quick question on that?
Sure, sure. And I forgot to say up front, feel free to interrupt at any time if you guys have questions, because I know this in particular is a confusing area, and I think it's probably worth spending more time on.
No, it's super helpful. So I just was wondering if there's, and I may have missed this, is there any data about how often people end up using it? Like in terms of if you recommend this sort of rescue use, like, and is there a warning sign if someone's like, I only use it for rescue, I use it 4 days out of the week? Like, can you mask a more severe asthma diagnosis kind of thing?
Yeah, so I think, that's a great point. And I think it's one thing to think about is if you start them on this, I think it's still important to assess asthma control from, if you think about the, sorry to jump back all the way, but one of the charts I was showing earlier, I think it's important to still, like, I'm putting them on a PRN therapy. And if they're still having daytime symptoms more than twice a week, if they're still using this quite frequently, if they're frequently having nighttime awakenings, then that's something to assess whether, and sorry, I'm just going to jump ahead, whether they need to essentially, and I'll talk a little bit about how to put this into practice a little bit more, step up to the next level, whether that means that there's someone that they're still having, if they're having frequent symptoms, should I put them on maintenance therapies with a higher dose inhaled corticosteroid? And I'll talk about those options, but I do think it's important when you make this decision that they're truly mild and that they're well controlled with this PRN option. It ended up being, for people in this trial, they ended up, and I think it's part of trial selection inevitably, where these people end up using their inhaler very rarely. They ended up using their inhaled corticosteroid much less than they would have if you just put them on a twice a day inhaler. But if someone's telling you that, hey, I'm still using my inhaler, sort of, you can think about where step 2 is here, twice or more a month, or if I'm still using things more frequently, that might be someone that you should step up at that point. The adverse events with typically, truthfully, using it even up to 4 times a day ends up being safe with that particularly inhaler, which is sort of marketed on the 80 microgram Symbicort dose. It ends up being safe for the most part without any adverse events. But I think one thing you run into is, the importance of reassessing, because, and I think that is we also had that problem prior when we were just putting people on a short acting beta agonist as needed for mild asthma, is that I think there's an important reassessment with the old way. There's also very important reassessment continuously with the new way. And I think you did bring up a great point with that question. I'm not sure if I answered it directly.
No, totally. And I just want to mention, so Gail Birkenblit had put in the chat, she was wondering if you actually had any luck with getting insurers to cover it by citing the GINA guidelines.
That's a great question. So I am overzealous about that. So I write a prescription. I actually say per GINA guidelines and all of mine. So I think you're probably getting some selection bias in terms of like the overzealousness I am and fear I have of it being rejected. So I sort of do preemptive communication about that, and I let my patients know, this is a different practice, so let us know if there are any issues with that. I primarily do like asthma and COPD care, so I do this fairly frequently. I haven't run into that as much. I will say one thing. This does become a little bit more complicated to implement when you have people who are sort of further down into the severe asthma category, where I'll talk about a little bit more, where when you're prescribing people multiple different types of long-acting inhalers, I think that's where things become a little bit more complicated. I've had more success for individuals in the step 1 area. But that's a great point. And I think, as Gail mentions, I am sort of cognizant of issues with insurance companies. And I do think in the next couple of years, I do think this will be easier to implement than it is probably right now. But jumping back to our Mr. W, I think, so this is an individual who's probably further along in the pipeline than that. So And we have to decide what kind of daily controller and rescue inhaler therapy we would start for Mr. W. So just to recap his symptoms, he's using his rescue inhaler twice a day. He's having at least a nighttime awakening per week. He has a recent exacerbation requiring steroids. So this is an individual where I've sort of given the answer away here, but it wouldn't be appropriate just to start him on a PRN. And like I said, the GINA guidelines, or this GINA step, is used primarily initially to figure out where to initially start someone. And this is a guy who's having symptoms most days. He's having a nighttime awakening. I didn't show you his lung function, but he was an individual with lower lung function. So he is someone where you would jump towards starting them on a medium dose inhaled corticosteroid plus a long-acting beta agonist. And just to give some framework for what that is, this is just a chart that shows different inhaled corticosteroid doses by different types, and those include beclomethasone, budesonide, fluticasone. It can come in combinations like Advair and Symbicort, amongst others. This isn't a dose equivalent chart, but this is more of a reference for comparison to what doses count as low, medium, and high. I mean, obviously, there are different considerations you want to take into account when choosing which drugs. I know in your practice, your increased considerations are surrounding individuals who are on protease inhibitors and CYP3A inhibitors, which may have a greater interaction with fluticasone. But other things that to keep in mind are just more insurance coverage and which one to pick along the way. Now, but remember, even though you're starting this individual on a medium dose inhaled corticosteroid and a long-acting beta agonist, which could be something like Symbicort or Advair in his case, it's important to continuously reassess, is this an adequate medication to control his disease and to control his symptoms? Because the goal is to keep someone as symptom-free as possible. So we take this back to Mr. W, where we make the choice to put him on this recommended therapy. We also put him on montelukast, which is known as Singulair, which is something we utilize often with people with allergic symptoms and asthma. But he still comes back to clinic in 4 weeks and reports continued use of his rescue inhaler and waking up with symptoms. So what do we think is the next line in terms of asthma management for this individual? Well, before thinking about next medication steps, I will say our practice at that point is to think about a few more basic things before jumping up to the next step, or step 5 in their case. And that's this other red box I've highlighted. And one thing I'll breeze by this because you guys are probably very familiar with this already, but it's important to make sure that you prescribe the medicine, that they're using it correctly. So one of the biggest things we do in our practice is to make sure they're using their inhalers correctly, which up to 80% may not be using their inhaler correctly. We often give spacers both for controller medications like Symbicort and rescue medications along the way. So making sure they have appropriate education about how to use their medication becomes a key component. After assessing adherence to therapy, I often think about other markers of disease control. I'll talk about RAS testing, which is different tests to look for allergic sensitizations that might suggest certain triggers. We often will check a CBC with DIF to evaluate eosinophils, which will be particularly relevant for when I talk about severe asthma therapy next. And then you also want to think about different modifiable risk factors, including environmental factors that maybe contribute, including allergens, if someone's smoking in the house. And then I'm always thinking about comorbidities, because if someone's coming to me with shortness of breath, I want to make sure it's their asthma and not their heart failure or other risk factors that might contribute. And I think about all of those things before I think about thinking about step-up therapy. Now, I will mention that there are a couple of other therapies that are also mentioned for individuals who are at this phase of disease control that you may want to be thinking about in your practice. One other medication that's thought about as add-on therapy is Teotropium Respirament, also Spiriva, which has been approved as an add-on controller. It has a larger role in COPD, the misformulation or the Respirament, as opposed to the other formulation, which is the HandiHaler, which is a pill that you crush and inhale. The Respirament has been approved for asthma. There is some evidence supporting it. I have not found in my practice that if someone has severe asthma and I put them on this HandiHaler, it'll be a game changer, but it is an option as far as additional therapy. There are options for people who are sensitized to desmites for immunotherapy, for allergen desensitization. There is a limited population that this is approved for. One thing to note is if you're considering, this is something you would refer to an allergist for, especially if they have known sensitizations to different allergens. We typically have to make sure they have well-controlled asthma before you're doing this, because actually this immunotherapy for desensitization can trigger asthma and symptoms. So it is a very select population you want to consider that for. There are more basic environmental control practices you can consider. The guidelines for the best environmental control practice to put into place are still being developed. And so EPR4, which is another set of asthma guidelines, is reviewing a number of different asthma environmental control practices. I've included this for reference. There isn't one evidence to support one environmental intervention that is going to change things dramatically above others. It often turns out if someone has, for example, or a cat or a dog they're allergic to, removing that hasn't been proven to be like the thing that's going to fix everything, because often people have multiple different allergens that are affecting them. So we often think about comprehensive strategies involving, pest removal, HEPA filtration, dust mite proof mattress and pillow covers. But oftentimes when people have complex allergen exposure, it is beneficial to refer them to allergy to help with environmental counseling and developing a comprehensive allergen mitigation strategy. So putting some of these factors into place for patient W, just remember he's someone who's still experiencing severe symptoms. He's on step 4 therapy with good inhaler technique. We sent some labs that have shown that he has 6.3% eosinophils. He has an elevated absolute eosinophil count of 490. This is an example of a RAS test to look for sensitization. That test that evaluates for different common allergens in the Northeast region where we're at. There's not a specific environmental control area that we found to address, although, he does remain with uncontrolled disease. So he's been we decided to put him on Teotropium, but he still has another ED presentation. So the question here is if he continues to have symptoms despite high dose despite his treatment and environmental modification, what other therapies can now be considered? And this is really where we jump to the step 5 therapy for severe asthma, which is the other area where there's been a lot of significant change. And I'm going to spend the remaining, the next 10 minutes or so discussing add-on therapies for severe asthma, which includes a number of biologic therapies, not because you guys will be doing this in your practice, but because to emphasize, I encourage you to refer a lot of these patients to us, because now we have a lot of options for patients with severe asthma, much more than we did even 3 years ago. And for a lot of patients in this category, the previous thought would be to put them on maintenance steroids every day with a lot of risk, which come with a lot of side effects. But we do have a number of therapies available in terms of biologic medication that I'll briefly go over to help understand what's available. And really, the first thing I'll do is just define severe asthma. It's really asthma that requires treatment with a high dose inhaled corticosteroid plus a secondary controller, which could be a medicine like Singulair or Symbicort, and it requires these medicines to prevent it from being uncontrolled, or one that remains uncontrolled despite adequate therapy. And within the way we think about severe asthma now is also within emerging phenotypes of disease, where we're really thinking about precision medicine of how to individualize care. And the way we think about it is really into T2 or type 2 mediated inflammation versus non-type 2 mediated. Really, T2 is really focused on allergic asthma and the eosinophil pathway. There are sort of neutrophilic asthma or later onset asthma that can be a little bit more complicated to control, which exists as a specific phenotype. But really, a lot of the emerging therapies have focused on this T2 phenotype that I'm really going to focus on. And briefly talking about what is type 2 inflammation, it's really something that affects 50% of individuals with severe asthma who have increased release of cytokines, including IL-5, IL-4, and IL-13 that lead to eosinophilic inflammation. And these really end up being targets of our disease modifying therapies going forward. And really utilizing simple blood counts like getting a CBC with DIF with eosinophils can really help us to identify those who are going to respond to therapy and have type 2 inflammation. There are personalized approaches that are being developed in utilizing biomarkers to help figure out who's going to respond to different therapies. Those include checking IgE levels, checking for eosinophils. We have exhaled biomarkers that we actually look at in our clinic, or the FeNO, which is another marker of allergic inflammation, which is really helping us to subtype asthma and to help us better treat patients who reach this degree of severe illness. And to target different endpoints, a number of different biologic therapies have been developed that target those cytokines, including IL-4, IL-13, IL-5, that work on the IgE pathway to impact eosinophil and mast cell activation in asthma. They've really been a game changer. And one of the biggest changes, I think, came in the study for this drug Mepolizumab, which works on IL-5. And the study came out in 2015. A couple of the investigators were from our center that really showed a dramatic improvement in severe asthma treatment and exacerbations with this Mepolizumab biologic therapy, which is an injectable drug, which took many people who were once steroid dependent and decreased exacerbations dramatically with actually very few side effects, which I can mention, but without really sort of significant adverse effects that really changed outcomes between the placebo groups and those receiving Mepolizumab. And really since then, a number of different therapies have been developed acting on different targets, all somewhat in this eosinophil pathway to decrease the number of exacerbations for people with severe asthma. I'll mention up front, the first drug that was a biologic that was available was something called Mepolizumab or Xolair that many of you have heard of, which targets IgE. I will say that's probably the least common one we use now. While there haven't been head-to-head trials, found anecdotally that seems to be less effective than some of the newer drugs that have been developed, including Mepolizumab. Dupilumab or Dupixent is another common one we use that has been approved for eosinophilic asthma or corticosteroid dependent asthma to really help us improve control. And a number of these have been approved for multiple indications. Dupilumab, for example, has been approved for severe atopic dermatitis and additionally to chronic rhinosinusitis with polyps, or what was formerly known as Samter's triad, with multiple indications available that we can utilize these medications for. And like I said before, it's really changed how we practice treatment for severe asthma. And what we found in actually looking at population-based databases, including NHANES, is we found that a very high percentage, as much as 80% of those with severe asthma would actually meet eligibility criteria for these current biologics. So that is really, and this is an option that is available for many people with once poorly controlled asthma. And these are the people, I've sort of been able to make the biggest impact on in my practice. And we sort of love to see, what options we have available for in asthma care. Now, just to close things out, I have talked about some of these biologic therapies, mostly to make you guys aware of options that we have available to continuously reassess treatment for severe asthma. There are some other treatments that are available for non-eosinophilic asthma once they are known to have severe disease. One is prolonged macrolide therapy, or azithromycin. There is some data that may suggest a decrease in exacerbations. There are some implications for resistance, but it is our practice is pretty variable in how we use this. There is better data on COPD versus asthma with this. And a therapy that existed before is bronchial thermoplasty, which is an interventional therapy to help sort of ablate some of the smooth muscle that's hyperreactive in the airways. I would say I have never referred anyone to this. This is something that was discussed at some point, and we sometimes do trials for this for people in a registry, but it is a very select population where this would be considered. I'm just mentioning this as sort of to note other therapies that might be available for individuals with severe asthma. Most recently, a drug became approved, Tezepelumab, which I have trouble saying myself, which is actually a new biologic agent that is, we've had some patients in the trial who did very well. That's been developed both for eosinophilic and non-eosinophilic asthma, which has recently become available and may change our practice for both T2 and non-T2 mediated asthma for people particularly on that severe spectrum. Just to mention, I mentioned this as just to note that we live in sort of an exciting time for asthma therapy where new drugs and new therapies are continuously being developed that give us option for care. Now, GINA, or the Global Initiative for Asthma, has really put together a set of guidelines, which I put a link to here that you can sort of reference just to be aware of in terms of a pocket guide that sort of gives us a framework for how to treat severe asthma, notice when to refer individuals. I think I would say the highlight of this is just for you guys to know. I think what we're often hoping to see before we make decisions is what their level of disease control is, making sure they're on appropriate therapy before we check eosinophils, we check labs, including IgE to make sure, but for considering some of these newer biologic therapies. And not to go through all this in detail, we are often, our approach is to often treat individuals, see what the response is. And like everything with asthma, we're continuously reassessing the response to therapy, reassessing whether all their symptoms are related to asthma or other comorbidities, and anything we can do to improve their care with communication between us and the pulmonary side and with people like you and general practices as well. So putting that into context, I hope this served in somewhat as a framework for what the most recent updates in the GINA guidelines for treatment of asthma are different options for stepwise management, both for sort of new changes for mild asthma and new options that are available for severe asthma for treatment. And with that, I hope I've emphasized the importance of sort of recognizing asthma as a chronic condition, which is really frames how we approach treatment for both mild and severe asthma. And I think when there is time, if you guys have time, I think these, there are a couple slides, these slides can help sort of go through the framework of how to step up therapy along the way. A key component of that, with reviewing the GIA guidelines, is understanding that the diagnosis is iterative. It's important to confirm the disease. Assessment is iterative, understanding the severity and control changes, and treatment strategies with asthma are ongoing with these new drugs that are becoming available. And with that, why don't I stop there and I can leave time for any questions that might be available and hopefully clarify anything that may have been confusing along the way.
Thank you so much. That was amazing. If anybody has questions, you can either put them in the chat or just unmute. I'll start off with one more just that I feel like comes up a lot. When someone has a recent sort of respiratory infection and then has like a, what's the time frame for like this iterative diagnosis and evaluation of asthma symptoms? So if they have an uptick of symptoms, like how long before you think like, oh, I should refer this person for more interventions versus this is just a post-viral exacerbation of their underlying condition?
Yeah, so the guidelines, their recommendation is like reassess in 2 to 6 weeks after for like an unstable control period to make adjustments. That's sort of just a gestalt measurement, but I think we often think about in the sort of the 4 to 6 week range to see if people have gone back to their baseline change. Typically, those are sort of the guidelines that have been recommended. When we think about exacerbations unrelated to viral illnesses, we're often hoping to reassess where they are a couple of weeks after, just to make sure that that exacerbation itself has been adequately treated.
Great, that's super helpful. Anybody else with other questions?
And I include some of the slides from the the guidelines on when to reassess therapy as well, as far as a timeline if to be available if anyone needs that.
Last very practical question. Are you guys in the era of COVID? Are you doing a lot of pulmonary function testing?
Yeah, so that's an ever evolving thing, and I apologize for not like putting some of this in the context of COVID. So our pulmonary function practice is back to where we're still doing frequent pulmonary function tests. Both here, both at JHH and Bayview. One thing that's changed is that there used to be a lab at Green Springs that was convenient for people close to that area. I think that is my knowledge, and I could be wrong, is that is not currently operational. There are differences in practices in how we do lung function testing. For patients that are fully vaccinated, and I know some discussion surrounding that, we don't require a negative COVID test prior. For patients who are unvaccinated, they require a negative COVID test prior to getting PFTs. We are taking more significant precautions in how we're doing lung function tests to make them safer than before. Like, all the staff is in N95s and full PPEs. We also use viral filters and adjusted HEPA filtration within the lung function lab to reduce our risk associated with that. I can't say for sure, there currently aren't plans to change that with the upcoming waves, but I think with a lot of things like COVID, I think always there always could be some change.
Great. Well, we're pretty close to the top of the hour, so if nobody has any additional questions, just some thanks for such a great talk. This is a really, really useful review for a problem that comes up so frequently, and really thank you so much for taking the time to come. And just as a future advertisement, Dr. Raju did say he might return to talk about COPD if we ask him, which I would love to hear from you later in the year for those patients as well.
Right. Well, I appreciate your time. And like I said, as you mentioned, feel free to reach out to me. If you feel free to email me if you have any questions about asthma or other things. Also, I'm available for pulmonary referrals. Even if it's not my area of expertise, I think sort of navigating some of the pulmonary world can be challenging. So I could at least try to point you in the right direction if I'm not the best person to see that patient.
Thank you so much. That's a very generous offer. All right, well, thanks to everybody, and everyone have a good holiday, and we'll see you January 7th for Tom Quinn to tell us about the global HIV epidemic.